think that all government is a waste of taxpayer money.
This government is diseased. It's like a big, fat, angry slob spending money it doesn't have on crap it doesn't need. Me want more pointless social programs. Yummy, yummy, yum.
That's what government does, Ron.
I have a joke for you.
Okay.
The government in this town is excellent and uses your tax dollars efficiently. This is your lunch. You should be able to do whatever you want to with this, right? But here I come, the government, and I get to take 40% of your lunch. And that, Lauren, is how taxes work.
2020.
That's a stretch.
Fine. 2024. I win. We move in there. I'll take the West Wing, you take the East Wing, and you can be the first gentleman.
Well, the reason you're here is, I'm told, you've done such a great job in your town and in the state of Indiana. And I just want to say congratulations for your public service.
And I just want to say thank you.
Well, you're very welcome. You're very welcome. You're very welcome.
You're very handsome.
I think we're all done.
Well, you're very nice.
Okay,
But
thank you.
Thank you very much.
Thank you very much. We'll see you tomorrow.
Well, you will?
Thank you, Mr. Vice President.
You're welcome.
You don't let anything happen to him. Do you understand me? He is precious cargo.
Obviously, these are fictional characters and satire. But no matter where you stand politically, we can agree that government and politics play a significant role in most areas of our country, especially as it pertains to healthcare. But how do politics and healthcare services affect nursing practice? And why does the government have such an interest in healthcare in the first place? A lot of it has to do with, you guessed it, money and how to reduce cost. The United States spends more on healthcare than any other nation. In fact, it spends approximately 2.5 times more than the average of other high-income countries. The rapid increase in healthcare spending in the U.S. over the past 2 decades, and its anticipated growth in the coming years, can be tied inextricably to the increasing number of people with multiple chronic illnesses. It is estimated that 75% of the more than $2.5 trillion we spend annually on healthcare are related to chronic diseases. The 2 government healthcare services we are most familiar with are Medicaid and Medicare, also known as CMS, Centers for Medicare and Medicaid Services, which were signed into law in 1965 by President Lyndon B. Johnson. These programs spend well over $1 trillion each year to help those who are elderly, disabled, or of low socioeconomic status, so that they have health care coverage and access to services. This affects nursing and how we document, and the types of services we can implement. Some doctors won't even see Medicaid and Medicare patients because the reimbursement rate is so low. They would have to see significantly more patients to equal the amount they could make off a patient with private payer insurance. Perhaps if this outrageous price tag brought value, we as a nation would accept the expense. After all, healthcare is more vital than most other goods or services. However, the reality is that despite outspending all other comparable high-income nations, our system ranks last or near last on measures of health, quality, access, and cost. The United States has higher infant mortality rates, higher mortality rates that result from preventable diseases, higher rates of medical, medication, and laboratory errors, and higher disease burden. Due to the high demand for quality healthcare and lack of available providers, many nurses have been filling the gap by pursuing advanced nursing degrees and becoming mid-level providers. This, coupled with the significant advances in technology over recent years, have redefined how we recognize nurses in the care setting. The role of technology in healthcare. With us today, we have an expert in the field. Adam Ray has 15 years in leading technology initiatives across both the inpatient and outpatient setting. Hi, Adam. Thank you so much for being with us today.
Absolutely. Glad to be here.
So, as a leading expert in healthcare information technology, could you speak specifically on electronic medical records over the past 15 to 20 years and how it's affected physician and nursing practice?
So this is exactly where I started at in the space.
helping doctors and nurses move away from traditional paper charts toward an electronic medical record. But what I can tell you is it's opened up a whole new world when it comes to data sharing, integration, things like that. The ability now to consult on patients, whether they reside in your health system or they're out of state in a health system somewhere else, those are all possibilities today, which they weren't historically. From a technology standpoint, the ability to provide more security and protection around patient health information. That's something we can do now, where before you had so much physical data that you had to manage. Because it's logical, we have a lot more pathways with technology to do that. The other part's efficiencies. There have been some improvements in efficiencies when it comes to paper charts and the reduction of some of those paper processes, but now we have digitized processes, and you have work queues and different types of functions that have to happen inside the EMR. So I don't know if things are more efficient now than they were before. I can tell you that paper costs have gone down, but I also know that technology costs have gone up.
What are some specific quality initiatives that are tied to quality in the care setting?
So the original quality program, I guess you can call it, was Meaningful Use. That program and the reimbursement tie that was associated really is directly responsible for the rapid EMR adoption that we've seen in the last decade. Now I think it's called MIPS, but it's still alive and well, still tied to the reimbursement model from CMS. There's another program that I'm involved in the radiology space. I'm the committee chair at our organization, and it's called Clinical Decision Support. So basically, before a certain diagnostic imaging study can be complete, an appropriateness score has to be granted, and it's got to be based off of the diagnosis codes that were captured during the treating physician encounter. So really the goal, I guess, with that is to reduce unnecessary tests and the costs that are associated with them. That's one thing that's pretty active in the outpatient space where I reside today.
Could you talk about how reimbursement has been leveraged to drive adoption of governmental programs?
So I'm going to speak to this from my experience. It may not be everyone's, but with most of these programs, there's typically not a positive return on investment for healthcare companies. The staff required, the additional processes, maybe vendor that needs to be engaged to be able to facilitate and fulfill the requirements for these programs typically doesn't outweigh any type of incentive that's associated. The core of this really is finding ways to reduce costs for the government payers. So if you look at most of these programs, it's really designed around reducing services, minimizing duplicate exams, things of that nature. However, on a positive note, I do believe that these programs do increase provider accountability, and they help to ensure services are rendered only when they're necessary. That was an issue we had before. We didn't have that visibility. That was a big part of it as well, not knowing if a patient had been seen somewhere else or had something else prescribed to them from another physician. So there are some good things that come out of it, but typically the driver for most of these is reducing the cost.
Adam, how has COVID changed information technology in care?
Yeah, I think most healthcare companies have taken a hit because of COVID. For us specifically, elective procedures like mammography screenings, lung screenings, we had a huge increase of no-shows for those types of exams. One thing that we implemented was called a virtual waiting room. Virtual waiting room essentially allowed patients to fill out all their registration forms, provide all their orders, insurance, driver's license, things like that, to us directly from their phone while they're sitting in the parking lot in their car. Once we received everything, we were able to send them a text message to say, "Hey, Mr. or Mrs. Patient, we're ready to see you." At that point, the patient comes in, they bypass what we know as the traditional waiting room and go back and have their exam. So that's something we did to kind of mitigate some of those fears, and we found that's been successful.
There are almost 4.2 million RNs. 950,000 LPNs, LVNs, and over 325,000 nurse practitioners licensed in the U.S. There are 4 times as many nurses in the United States than there are physicians. Nurses are known to be some of the most trusted professionals in the medical field and have been for nearly 2 decades. Their voices carry weight and are considered not just authoritative, but ethical, honest, and patient-centered. Nurses' influence on healthcare policy cannot be understated. Speaking on how politics have shaped nursing roles and practice, we have Donna Reardon, a nurse and nurse leader of 30 years, joining us today. So could you tell us about some of the changes you have seen in nursing practice over the past 31 years and how politics influence these changes?
My name is Donna Reardon, and I am a registered nurse. I currently serve as the Vice President of Women and Children's Services at Summerville Medical Center in Summerville, South Carolina. I graduated with my associate's degree in 1991 and started my first job as a new grad. In my 31 years of nursing, I've seen lots of changes in nursing practice, and politics have played a big role and have influenced those changes. We've implemented universal precautions. I've also seen changes with DRGs. Back in early 90s, patients could drop off their mom or an elderly loved one while they went on vacation and would be admitted to the hospital for the week while they were gone, and they would convalesce, get all their pap smears, get all their tests and everything done, and we'd bill Medicare or their insurance, and they would pay 100% for the care. It was fee for service. Well, the government came in and said, wait a minute here. These things can be done on outpatient. These patients aren't sick. We're paying a lot of money. So they gave us a date. As of a certain date, we're going to no longer pay fee for service. We're going to go to DRG, which is diagnostic related groups, and we're going to give you a set fee for this patient's care based on their diagnosis. And I'm just going to give you an example. One of them would be community-acquired pneumonia. What happened was the government said, Medicare said, we're only going to pay, and this is an arbitrary number, but it's just easy to understand. We're going to pay you $100 for that if a patient comes in and admitted to your hospital for you to take care of them for community-acquired pneumonia. So in order for hospitals to make any money to be able to keep the doors open, they had to be able to provide that care within that $100. And not only within the $100, but even less than that, they had to provide maybe the care for $90 so they could make $10 off that at admission. So what happened is that we created this way to make sure that everybody was taken care of the same way based on that diagnosis. Doctors like to call it cookbook medicine, but hence the birth of clinical pathways. Clinical pathways were on day 1 for community-acquired pneumonia. This is what you do. Day 2, we do this. Day 3, you do this. And day 4, you should be discharged to go home. If you weren't ready to be discharged to go home, it didn't matter. You weren't going to get any more money. Length of stay, throughput began back in the early 90s, and we're still dealing with that today.
How can nurses influence policy? Do you have a personal story or example of when you were part of or witnessed nurses coming together and lobbying for change?
One time that I remember how nursing really impacted change and said no to the government was when I first became a nurse in 1991, and I've always been an OB. Medicare, not Medicare, but Medicaid and insurance companies said, we're only going to pay for a 24-hour stay after vaginal delivery for these moms that deliver, and that's all we were going to get. So if you provide 24 hours of care for a mom who just had a new baby, at the 24-hour mark, they had to be discharged because we weren't going to get reimbursed. So anything after 24 hours, we were just going to absorb as an organization. Hospitals quickly went and said, how do we pivot and make this work? So they built these LDRPs, which labor, delivery, recovery, and postpartum units, which were very expensive, but they were able to turn them over within 24 hours. So what happened was the government said, or the insurance company said, we'll pay for a patient visit to the home, a home visit where you can go in and do a well baby check and make sure the baby's okay. What happened was when we were going in and visiting these homes and checking on these babies were not eating, they were dehydrated, they were had high bilirubins, they were being readmitted to the hospital because they were not thriving. We saw so many of these cases and the outcomes were terrible purely based on reimbursement that nursing said, enough. We're not going to tolerate this. Is not safe. So nurses came together across the nation with physicians and they marched on Washington and lobbied for safer care for these moms. And they overturned that ruling and mandated that insurance companies and Medicaid paid for 2 days, a minimum 2 day stay for these moms with these new babies for vaginal delivery and 3 days minimum for a C-section. And we saw that infant mortality and morbidity rate decrease just with that change. And that was a huge impact on healthcare that nurses had that changed the political arena.
And the last question I want to ask you is, do you have any advice or encouragement for new nurses and how they can become more involved in their practice?
How can you become involved? I will tell you, don't be quiet. You as new grads need to raise your hand. When you start a new job, every unit should have a unit-based council. Be a part of your governing body at your local level and your unit level. Join your professional practice organizations. Every specialty has one. Some of the barriers and challenges, it is kind of cost prohibitive. Some of the membership are pretty expensive. Some hospitals, as part of their way to attract nurses, cover that fee. And if they do, take advantage of that. Be a part of that. Those are the organizations, the professional practice organizations that are going to change nursing practice. See something, say something. Don't be a silent observer. Be that advocate for your patients. Be that voice. And don't be that nurse who complains about what's not right but doesn't join any group that can make the change. Be the change that you want to see in practice. Be that nurse that you want to work with. Be that nurse that you know when they're there working, it's going to be a great day no matter how busy it is. When I started, nurses were, and we still are today, and this is one area that I think that needs to change, but if you look at, doctors can bill for their services, the hospital bills for their services, the anesthesia bills for their services, all the other radiology, all the other specialties bill, but you don't see a nursing fee. And unfortunately, nursing care is built into the room charge. I don't think that's okay. Nursing's at the heart of everything that is patient care. We need to have a voice. Without nurses, there would be no patient care.
As a nurse, we have a duty and a responsibility to our profession and our patients. It is important that we become politically aware and active in our field and specialty. There are many governing bodies in nursing. You can have a voice and be a part of change. Remember, you have a voice.
Thank you, Senator Johnson, for giving nurses the opportunity to come and represent our patients, because as you can see, we're not often thought of as leading professionals, though we are the missing link between the doctors and the patients. So thank you so much for this time.
Okay. Thank you for being a nurse.